Good afternoon, my name is Hope Frost, and on behalf of SBK Healthcare, I am delighted to welcome you to this Initiating and Managing SGLT2 Inhibitors in Type 2 Diabetes webinar. Thank you for joining us. Welcome onto screen, Laura Edgar, who is a practice nurse from the Robert Darbishire practice. And I'm going to hand over to Laura for her presentation now.
My name's Laura. I'm a practice nurse from the Robert Darbishire in central Manchester. I qualified as a practice nurse in 2016, so I've been practice nursing for about the last 5 years. I'll be honest, prior to being a practice nurse, I had little to no knowledge or background information on diabetes. I grew up with a friend who had type 1 diabetes, and my experience with her was she got more sweets and more crisps than me. And she also got late night Mars bars. Now, in reality, these were to manage hypos. But as a child, you don't know any better. So yeah, like I said, that was my only real experience. But like I said, I became a practice nurse about 5 years ago. This happened at the same time. Sorry, when I started my job at the Robert Darbishire, this was the same time as the CODES team started. So the CODES are the Community Diabetes Education Service for Manchester. And that's Nikki, who's here today. She's part of the CODES team. And they really gave a lot of support for our complex diabetic patients. And this is really where my diabetic interest came from. So yeah, welcome today. So today's session, I've tried to really cover the points, learning points and objectives that people put in when they signed up to the webinar. So thank you for that. They're really, really useful in helping me sort of create these slides. So today's session, I'm trying to do a whistle-stop tour of SGLT2 inhibitors and just basically demonstrate how I, as a practice nurse, will use these for my patients in clinic. I'm hoping that I'll be able to give you some practical tips and tools to use when you see your patients. I'll be honest, I haven't focused too much on, the trials, studies. That's not really practice. We're not really looking for that from practice nurses' point of view. But I do hope that you'll really find today useful. So we're going to focus on what are SGLT2s, how do they work, risks and benefits of using these with patients. Again, like I say, some useful tools and resources that we use in clinic. Once you've decided that you're going to use an SGLT2, how do you choose which one? Drug interactions to be mindful of, sick day rules, local guidelines, and then a couple of case studies at the end. So what are SGLT2s? Well, they're a group of oral medications that we use to treat type 2 diabetes. They're actually relatively new. Canagliflozin came into play about 2013. But the main ones that you'll see prescribed are your empagliflozin, dapagliflozin, and your canagliflozin. They do also come in different preparations, but they are quite expensive. I've been told by our pharmacy team they're quite expensive. However, these are the main ones that you will see. You will also notice they do end in gliflozin. This is a really simple way of spotting these medications when you're wading through someone's medication notes. One of the most common confusions that we see as practice nurses, and I thought it was worth touching on today, was we will talk a lot about the generic names in practice. So that may be, I'm talking to a patient and I'm talking about empagliflozin. That patient, however, may receive Jardiance from the pharmacy. Now, it's the exact same medication, however, it can cause confusions with clinicians and also patients. We have it quite often where we do reviews, and I will say to a patient, okay, you're prescribed empagliflozin, 10 milligrams, and they say, no, I don't take that. And then it turns out they have Jardiance. So yeah, I just thought that was something useful to mention. So this is actually one of the slides from the CODES team, and they used it as part of our training. So I thought it was useful to just pop it in here, more to demonstrate, the different ways of managing blood glucose for diabetes. Most medications, they either work by reducing the amount of insulin, increasing the amount of insulin in the body, or increasing insulin sensitivity. Now, SGLT2s are actually slightly different. They work by blocking glucose reabsorption in the kidneys. So we'll touch a little bit more on this afterwards, and I've got a great video to show you as well. But yes, they block glucose reabsorption in the kidneys, subsequently reducing blood sugar overall. So I'm not going to get too technical, but I just thought the best way of understanding how the medication works is you do need to talk about the kidneys. So within the kidneys, there are tubes called nephrons. Now, they balance and filter electrolytes between the blood and the urine. The main things that do get reabsorbed from the kidneys back into the bloodstream are water and glucose, and then what isn't reabsorbed, that's what becomes the urine. So if you focus on the proximal tubule just here on this screen, this is where the reabsorption tends to happen. So you shouldn't normally find glucose in the urine unless it has your blood sugar has become particularly high. But yeah, most of it happens around the proximal tubule. And then within that proximal tubule, there is within the lining are sodium glucose link transporters, or SGLTs. Their job is to transport sodium and glucose back then into the bloodstream. This really is where the SGLT2 inhibitors work. That's where they target. They block the action of this reabsorption, ultimately reducing your blood sugar. I do actually have a very good little video here that I think Sarah's going to pop on for us. And this will help to explain it a little bit better.
The kidney is made up of about 1 million tiny tubes called nephrons, and these nephrons are responsible for filtering and balancing fluid and electrolytes between the blood and the urine. Now, the nephron consists of 5 main landmarks that you need to be aware of: the glomerulus, the proximal convoluted tubule, the loop of Henle, the distal convoluted tubule, and the collecting duct. Now, the glomerulus and the convoluted tubules are up in the cortex of the kidney, and the loop of Henle and the collecting duct pass down into the medulla of the kidney. How it works is water and small molecules are filtered from the blood into what we call the filtrate in the glomerulus, and then varying amounts of water and molecules are reabsorbed from the filtrate into the blood along the tubules, loop of Henle, and collecting ducts, and what's left in the filtrate becomes the urine. For the purpose of understanding SGLT2 inhibitors, we're most interested in the proximal tubule. Glucose is actively reabsorbed in the proximal tubule along with sodium. Normally, glucose is filtered passively into the filtrate in the glomerulus, and under normal conditions, all of this glucose is reabsorbed in the proximal tubule, so you shouldn't find any glucose in the urine. Where the blood glucose exceeds about 10 millimoles per litre, then the proximal tubule doesn't have enough capacity to reabsorb all of it, so you'll start to see glucose appearing in the urine. Let's look a little bit closer at the proximal tubule. There are cells that line the proximal tubule that have a molecule called the sodium glucose linked transporter, which we shorten to SGLT, on their luminal side. This transports sodium and glucose together across the cell membrane and out of the filtrate. This sodium and glucose then passively diffuses out of the other side of the cell into the interstitial fluid, where it's reabsorbed into the blood. This sodium-glucose link transporter is a target of the SGLT2 inhibitors such as dapagliflozin, and as the name suggests, they inhibit the action of the SGLT2 molecule and prevent the glucose that is filtered out of the blood in the glomerulus from being reabsorbed. And as a result, the glucose is secreted into the urine and the blood glucose stays low because it's not being reabsorbed in the proximal tubule. And this is how they reduce blood sugar and reduce the amount of sugar in the body. Let's look at the
now know a little bit more about SGLT2 inhibitors and how they work. So I thought we'd maybe talk a little bit about the risks associated, the benefits associated with SGLT2 inhibitors. So first off, they do not cause hypoglycemia. That's a real big benefit that we use for in clinic. They just simply don't work in this manner, to be honest. They aren't stimulating insulin production, and they don't contain any form of insulin. So it's great in terms of those patients where you'd be worried about risk of hypoglycemia. Now, when they are, for example, mixed with other agents, that could be insulin, that could be USUs, like maybe glycoside, you would need to be mindful of potential hypos, and you would potentially need to look at dose adjusting these medications. But again, that is very independent to that patient, and that's something that would be part of the review when starting that medication. The second benefit of SGLT2s is weight reduction. So you will often see a slight reduction in weight for patients who take SGLT2 inhibitors, normally only around a couple of kilograms or so, and realistically, most patients who are type 2 diabetics can afford to lose a couple of kilograms. This is mainly due to the calorie loss due to the glucose excretion. And then the last one I'm going to touch on here is about the blood pressure improvement. Again, most type 2 diabetics comes hand in hand with high blood pressure. This blood pressure reduction is mainly due to the fluid excretion and then the volume depletion associated with the weaning out the sugar, for want of a better way of saying it. Some of the studies have actually shown that empagliflozin and canagliflozin they provide enhanced cardiorenal benefits of this too, so it's just worth bearing in mind. It is really important though to highlight that although these can be benefits for some patients, this is not the case for all. So you would want to be very mindful of who's the patient in front of you and assessing what their needs are. So we're now looking at the risks associated with SGLT2 inhibitors. Your first one, thrush and UTIs. Now this is a pretty big one that we see in clinic. Yeah, we see it quite a lot, and it's something that can put patients off and clinicians off, but patients off mainly. It tends to be more common in women. However, it does happen in men as well. It's worth highlighting that. This is mainly due to, like I say, the kidneys are excreting this excess glucose by the urine. If you have any form of bacteria in the bladder, you're essentially feeding the bacteria with this increased glucose. And it's really important just to mention to patients about good genital hygiene. Again, just to reduce this risk of UTIs or thrush when you are considering this medication. Your second risk, side effect, so to speak, is your increased urinary frequency. Again, very common that we see patients complain of this when they do start these SGLT2 inhibitors. Again, it is the body passing more urine to get rid of this this excess glucose. You then got hypertension, or low blood pressure. So we've kind of touched on this as part of the pros. Like I said, it can be a pro for some people. However, if you've got a patient in front of you with already low blood pressure, you wouldn't want to necessarily use an SGLT2s. Next, you've got your risk of diabetic ketoacidosis, or DKA. This was actually a side effect found with SGLT2s during the trials. And again, it's just something to be mindful of, but we will touch on this a little bit more in a couple of slides ahead. And the last one here is just about the increased risk of lower limb amputations. Now, this is an increased risk mainly associated with canagliflozin. So you would want to be mindful of patients, for example, with amputations or maybe active leg ulcers. So yeah, I should say that we're not prescribers, the practitioners aren't prescribers in our practice, but I thought it was worth talking about drug interactions and considerations if you were to prescribe. Now, the main ones that we look at are thiazides and loop diuretics. mainly due to the risk of dehydration, just with the volume depletion and you're excreting all this extra urine and subsequent fluid. And then, like I said before, we've touched on the insulin and then sulfonylureas, such as glycoside. These are mainly a caution due to hypo risk. Again, we may just have to look at dose adjustments for these if you're adding in SGLT2s with them. I should say there are a lot of other considerations to consider, but you would want to look at the BNF for these. Like I say, we're not prescribers here, but I just wanted to highlight the main two that we would look at. So our main concerns really, as part of a diabetic review and in terms of medications, we want to reduce hypoglycemia, hypertension and dehydration. And yeah, if we're starting this medication, what do we want to be mindful of? So we briefly touched on DKA earlier, so let's just talk about that in a bit more detail because it's a really big part of SGLT2 inhibitors. Someone described diabetes as being a bad friend. Once you have it, it brings other bad friends with it. And I thought that was quite appropriate. It does not leave any organ untouched. So, like we said, one of the main complications with diabetes is actually ketoacidosis, or DKA. This is basically when there's a buildup of ketones and it causes the blood to become acidic, and mainly this is due to lack of insulin. Now, the mechanism by which the SGLT2 inhibitors cause this increased risk of DKA is not quite clear. However, there are a few factors that may predispose patients to this. So this could be low beta cell function reserve. It could be conditions that may restrict your food intake, maybe like an eating disorder, a sudden reduction in insulin, acute illness, or alcohol abuse. And again, these are things that you would factor into your review when you're considering these as SGLT2s as treatment. It's important that you give really good education to the patient if you are considering SGLT2s as a treatment option. So you'd want to maybe, I can see the screen here, highlight these symptoms, blurred vision, feeling tired, sleepy, make sure the patients are aware of this. It's really important that we give patients the autonomy to recognize and know their own body and when something isn't right, and also how to react to this. I also thought it was worth just mentioning that often you can have a normal blood sugar reading, a finger prick check, but actually your ketones can be raised. So that's something that is worth mentioning with patients. So can't talk about diabetes without sick day rules. They're a massive part of our diabetic reviews. And again, the main purpose of these is to reduce your risk of dehydration, DKA. So specifically, we're going to look today about sick day rules and SGLT2 inhibitors. We could go on, have a whole other webinar about just sick day rules, but specifically for SGLT2s, you just want to stop them if you are unable to eat and drink as normal. Same if you're vomiting, diarrhea, you would want to stop them. These can then be restarted again once you're eating and drinking normally. And again, it's really important, just hammer this home to patients about, recognizing these symptoms, knowing how to react in these situations and scenarios. You can see here, I've got a couple of examples of information leaflets that we give to patients. So yeah, these are both from Trend here, and this is a really, really useful resource that we have in clinic. It's just something that they can, they may be overwhelmed with the information that you're giving them in clinic. Give them these, tell them to take them home, have a read, and get in touch with any questions. That's what we go after and do here. You want to just make sure the patient feels independent, and they have the autonomy to look after their own health as well, So we've touched the basics of what these class of medications do, how they work, pros and cons, or risks and benefits associated with them. So I thought it might be useful just to talk about some of the resources that we use in clinic when we're looking at them as SGLT2s as a treatment option. So So you can see we've already talked about trend, but the majority of our resources, they come from Diabetes UK, the Association of British Clinical Diabetologists, Primary Care Diabetes Society, and again, trend there. So what I've done is I've just included some of our main resources in the upcoming slides. I just thought it'd be nice to have a little look at each of them, maybe do like a little snapshot into how I might use those. And what I've tried to do is categorize them into the more meaty ones, the ones you might look at, you know, prior to seeing a patient, maybe after you've seen a patient, and then the others are more quick reference tools. So first off, like I say, these are the more meaty ones of the ones we use. Again, they're both aimed at healthcare professionals who are looking at SGLT2s for type 2 diabetics. You'll see the first one is from the Association of British Clinical Diabetologists, and then the second one again is from Trend. You see we use Trend quite often because they're brilliant. I personally tend to gravitate towards the Trend document, possibly because this is the first one I got familiar with, so I was a bit more comfortable with it. But I know my colleagues, they tend to use the first one from the Association of British Clinical Diabetologists. It's the same information, just in different versions. I actually tend to keep these on my desktop or saved as a link on my browser just for quick reference as well. So the next few slides here, they're more the quick reference resources. Again, I tend to have these saved at all times for quick and easy access. So this first one here is from the American Diabetes Association, and they created like a traffic light system to show who is suitable for SGLT2 inhibitors and who maybe wouldn't be. So you can see, looking here, you've got your green section. These are people who would be suitable to have them prescribed. They may have CVD, heart failure, they might be overweight, or they may be vulnerable to hypos. So these are your green patients that are okay to go ahead with them. Amber zone here, prescribe with caution. This may be, for example, if your EGFR was reduced. So it's just, again, something to be mindful of. However, it is worth mentioning, hot off the press, dapagliflozin is now actually licensed down to an EGFR of 15, providing there's no ACR. And then moving on to the red zone, the red category, sorry, these are people you wouldn't really want to be using SGLT2 inhibitors for. They may have a history of DKA, they may have increased excess alcohol intake, or they could be pregnant, planning to get pregnant. And again, these are all things that will be part of the conversation as part of your review. This is possibly the most useful resource that I have in clinic. It's absolutely fantastic. So basically, this covers all the main categories of your oral diabetic medications, and then some of the injectables as well. It doesn't look at insulin, but like I say, it's a majority of the oral ones. It highlights the main things that you want to consider, everything you need to know on one sheet. So you've got your glycemic efficacy, impact on weight, cardiovascular benefits, key advantages, precautions on when to prescribe or how to prescribe safely. And it just summarizes it really quite nicely. Like I say, I use this pretty much on a daily basis, if I'm honest. And then you can see SGLT2 inhibitors are there. And lastly, really another useful tool is from the American Diabetes Association. This looks much more complex than it really is, to be honest. You simply just want to look at this. What's your main concern? If you look at the purple column or the red column, it's cardiovascular concerns or heart failure, CKD. Looking at the yellow one, the yellow column, you're looking at risks of hypoglycemia if this is something that you want to minimize. Look at your blue column, again, do you want to promote weight loss? That's your column. At the end one, something we don't really consider too much in as practice nurses is your cost. So I just thought it was worth, putting into context the sort of the thoughts that might be swirling around my head when I've got a patient in front of me. What are the questions I'm thinking? What am I asking? What am I looking at their notes for? And I actually tend to write blood results down, blood pressure, BMI, cardiac history, and I'll tend to have that on a piece of paper in front of me when I'm doing the review. Again, just for quick reference so that I can know what is going on with this patient. I just thought this is quite a nice way of sort of demonstrating what I would be thinking. Now, our team, like I say, we're not prescribers, but what we tend to do is we will make a suggestion to the GP, and then if they're in agreement, they'll prescribe. 9 times out of 10, they do go ahead with what we suggest. So you've decided that SGLT2s are an option for the patient you've got in front of you. So your next question might be, well, how do you choose which one? Empagliflozin, dapagliflozin, canagliflozin, which one would you go for? So in Manchester, we have local guidelines called GMMG guidelines, and they suggest that canagliflozin is our first choice. You will have guidelines specific to you, so I would suggest having a look at them because they may differ from where you're based. Yeah, like I say, for Manchester, it's canagliflozin. You've then got your second and third line choices of dapagliflozin and empagliflozin, if canagliflozin isn't appropriate. And again, just as we mentioned previously, dapagliflozin is now licensed to be used with an EGFR as low as 15, providing there's no ACR. So quite often in clinic, we will see if canagliflozin isn't appropriate due to an EGFR, this is where dapagliflozin is come in. So I thought we could maybe consolidate what we've gone through there with a couple of case studies. So meet Judy. So Judy is 81. She's severely frail. She lives at home and she does have regular carers throughout the day. She doesn't really have a big appetite. She doesn't tend to eat and drink without encouragement. But you can see from her blood results that her HbA1c was 66 and her EGFR was 80. She's previously been under urology for urinary incontinence, and she's also under podiatry at the moment for active leg ulceration, and these are also being addressed by the district nurses. She's also told you, she's disclosed to you that she's having recurrent thrush, but she doesn't really want to bother the GP with this, so she's been treating this herself. This may be important because it may not be on their actual records when you're looking through. So again, it's always important to take what's on the record, but also have that conversation. So some of the main thoughts regarding Judy, she's severely frail, so we wouldn't want to cause any hypoglycemia. So SGLT2s, there's a tick, that's a good option. However, based on her age and frailty, we don't want her HbA1c to be too low. So HbA1c of 66 actually might be okay for her. It's also worth mentioning she's not really independent. She's having those carers. She's possibly maybe not able to look after herself. She'd also mentioned about active ulceration in her legs. Again, canagliflozin wouldn't really be suitable with that. Thrush. She's told you she's having thrush, but the GP may not know about it. So yeah, you would want to be mindful of that, and SGLT2 is potentially aggravating this. No, she's not mentioned necessarily about UTIs, but it is worth mentioning that this is common admission for the elderly patients. So if you've got a medication that may cause UTIs, increase confusion, increase admissions to the hospital, these are just things you want to be mindful of. It is also worth mentioning that her EGFR is safe to give an SGLT2 inhibitor for, but based on her social factors, I would probably avoid. And then lastly, we've got Gary. So Gary's 56. He works as a lorry driver. He lives at home with his wife and 2 children. His HbA1c was 65 and his EGFR was above 90. His BMI is 38, and he's currently taking metformin, 500 milligrams, 2 twice a day, and he has very good compliance with these. He has a carb-heavy diet, and he does enjoy a pint at the weekend, but this is like a social pint, it's no binge drinking. And it is also worth mentioning that he has had an MI in 2015. So thoughts on Gary? He's independent, he's driving a lorry, you know, he's out and about doing long distance driving. He does drive for a living. And again, there's that low hypo risk with SGLT2 inhibitors. So this wouldn't impact his job, which, you know, is a really big factor to consider. His BMI is 38, so he would probably benefit from reducing that, you know, losing a few kilograms. Again, one of the side effects, and a positive side effect for Gary, is obviously the weight loss. Just going back to Judy, for example, this is an example of where weight loss is good for one patient, but maybe not for another. So for Gary, it's a positive side effect. He eats well, very low risk of, you know, dehydration. He's eating and drinking as normal. He does enjoy a pint. Again, I mainly put this in to just show that the SGLT2s are fine with alcohol. It's just when it becomes binge drinking or alcohol in excess that would be a concern, that DKA risk. And again, last point, just about cardiovascular benefits in relation to his MI in 2015. That would be a really big factor for me to choose an SGLT2 for him. So in case it wasn't obvious, SGLT2 will be quite suitable for Gary. So you probably have spoken to Gary, he's in front of you as you're a patient. What advice would you maybe tell him? So you would want to make sure that he is well hydrated when he's taking this medication, especially if he's potentially on long drives. So I would maybe say to him to carry a sugar-free drink with him. However, to make sure that he is aware that there is that risk of increased frequency. So it may be he has to, you know, stop off during those long drives, just something to consider. Again, just advise about alcohol, not to binge drink or have alcohol in excess, but a pint at the weekend is fine. And again, just reiterate those symptoms of DKA. So just to summarize, I've introduced you to the class of SGLT2s. I hope you find it useful. I know it's a bit of a whistle-stop tour, but it's now over to you guys for some Q&As.
That's brilliant. Thank you so much, Laura. That was fantastic. We have got lots of questions, so I will get, there we go. Hi, Naresh. Hi, Nicola. Thank you for joining us. So we will start by at the top, and we'll work our way through some of the questions. So the first one is, how can SGLT2 lead to amputation?
Yeah, so SGLT2s and amputations, the thing is, the evidence is not great, all right, about why it exactly causes amputations, all right, but the risk is high because of the incidence of dehydration and everything, diuresis and everything that can happen, and especially if they have a rear foot which is at high risk, it puts them more at risk of developing amputation. So it does not mean that SGLT2s cause amputations, so it can promote amputations in a high-risk foot, all right? So that's the thing to consider. So I want people not to go away and think SGLT2s cause amputation.
And I think it's really important as well, because in the three main research trials for dapagliflozin, canagliflozin, empagliflozin, it was only in one of them, and they felt it was maybe to do more with the control group rather than in the study. And where they've looked since at real world data, and there's been more of the renal trials, that hasn't come up again, has it? So it's very much risk versus benefit. So a high risk foot, I don't think we should be initiating, but as I say, as Naresh was saying, it's not going to actually cause the amputation, but in a high risk foot it could exacerbate things.
Yeah, so just be wary of a high risk foot. Get some advice if you're going to start SGLT2. That's it. All right.
Brilliant. Thank you very much. So the next question is, are SGLT2 safe for use in people with peripheral neuropathy?
Good question. I think peripheral neuropathy puts again patient's feet at risk of developing ulcers, etc. All right, so there is no evidence that you can't. There's no guidance that you can't use it in people with peripheral neuropathy. But I think you'll have a high index of suspicion because these people are prone to develop ulcers, thereby infections, thereby can lead to amputation. So just be cautious in these people. Make sure they understand about examining their feet every day, if not every week, every day at least. Make sure you check the feet every time they come in to see you. All right, footwear, all those things are vital in this group of people.
And it's really important that the person with diabetes as well knows, you know, if they do experience a problem, who do they need to contact, and where, you know, that is the big thing, because, you know, you can give as much information, and we'll often see people in the foot clinic and they said, well, I had it for a few weeks, but I didn't know what to do. And I think because of COVID, people have been more reluctant to come forward as well. But what I would say is, where you're ever in doubt, or you feel uncertain, then always speak with your teams, with your specialist teams. Laura spoke at the top about how we all work as one integrated care team, and I think it's really important. You know, we're always happy to get an email and give advice. So, you know, if you're not sure, then do speak to your teams that are around you. We're all here to help.
So before you finish, I mean, Laura also said about education about the person with diabetes. I think that is important. So, I mean, she touched on some really key points, but seemingly didn't sound important. But I think some of the stuff she said about education, advising them about the risks associated with SGLT2s, and somebody put in the chat about annual foot checks. That is so important. And especially in COVID times, people have not had the feet check. All right. So just be wary when you're starting SGLT2s remotely. Get them to look at the feet. Yeah.
Okay, that's great. Thank you. So are SGLT2 safe? Oh, we've done that one, sorry. Do you treat and stop SGLT2, or do you continue SGLT2 to treat a UTI?
What would you do, Laura, for this, for UTIs? Would you stop the SGLT2, or what's your experience? What do you do?
From experience, we just, you know, it is a known side effect. I had a lady only about a couple of months ago who was having recurrent UTIs, and no one ever picked up that she was on an SGLT2. So we actually swapped her. We took her off the SGLT2 and onto a Trulicity, and yet the UTI stopped. So yeah, you know, it's.
I think you're right. It depends on that. I think. If it's a one-off, I mean, as long as you explain to the patient, if it's a one-off, there's really no reason to stop the SGLT2. Treat them. If it doesn't settle, then review the situation again. But I wouldn't stop that if one person develops a UTI whilst on the SGLT2.
Yeah. And also, it would be important to know what sort of degree the UTI is affecting them. So as Laura pointed out before, if they had a severe infection from the UTI, you might want to suspend the SGLT2 as part of your sick day guidance. You know, particularly an older person, they might be very unwell with that. So you might just suspend it whilst they're unwell with the infection, then restart it. But as Laura said, I think if they're getting recurrent infections, then you would look at stopping. Very often it's about individualising care, isn't it? And often it's about having that conversation with the person with diabetes. We've had a couple of patients who have had a few recurrent thrush episodes, but they've been so pleased with how the SGLT2 has worked for them in terms of weight loss and A1C reduction, that they've wanted to carry on with it. Yeah. And then other people have had less of a threshold. So yeah, it's you know, don't forget to involve the person with diabetes in making these.
Yeah, absolutely.
Yeah.
Okay. So someone's written, I thought that instead of the frequency of urine, it was more the fact that there would be greater volume. Is that correct?
Generally, the research says that you'll tend to void urine one more time in a day. So you'll pass, you know, so there will be that extra frequency. Sometimes you find, particularly in male patients, you often get an urgency. So if they're watching the football or they're watching a film, they just can't wait for the last 5 minutes, they need to go. But again, most people seem to be fine with that because they are finding a positive benefit, and you know, it's not a common complaint.
So was the question related just about UTIs being caused by frequency?
No, it just said was it that they had they voided greater amounts, or was it more frequency? One more.
All right, okay, that's fine.
Brilliant. Could you please clarify how SGLT2 risks DKA?
Good question. Now, SGLT2s can cause DKA in people who have normal blood sugar levels, all right? So it is partly to do with the diuretic effect and other effects that it has on the kidney, that it actually promotes DKA. But remember, it tends to happen in people who are poorly, unwell, so if you're a fit young person, very unlikely to get DKA. If you're unwell, thin, frail, those sort of things, and you're what are called insulinopenic, you tend to develop DKA. So as a general rule, I wouldn't worry too much about DKA as long as you're giving them the proper sick day advice guidance, like Laura pointed out, which is the main thing, all right? And the risks are very low, the numbers are very low as well. So you just have to be cautious in people with very high HbA1cs, very thin patients, all right? And you think, well, the person doesn't fit the criteria for a type 2 diabetes, you would be careful about starting SGLT2s in these people.
And I think Laura highlighted the risk-benefit tool. So, people that are doing a ketogenic diet, and a lot of people are actually going off and doing that themselves now with the low carbs, low calories.
Yeah.
So we need to be careful there as well. There was a few questions which came through about type 1 diabetes and SGLT2 inhibitors. Dapagliflozin is licensed for type 1 diabetes, but it must be done under specialist care. So it's not anything that primary care should be doing, starting an SGLT2 in somebody with type 1 diabetes.
And they will be more at risk of developing DKA
Absolutely.
as well. So do not start DAPA in type 1, please.
Okay, perfect. What is the recommendation for patients who wish to fast, e.g. for Ramadan?
Well, I think the recommendations, I don't think they change much with regards to use of SGLT2, because it is because if they're having their breakfast in the morning, I think that, now you could argue because they're peeing more, they could get dehydrated more, they want to drink more and things like that. There is that element of, how they're going to fast if they're going to be feeling dehydrated. I think advising them about the side effects of the SGLT2 during Ramadan, if they're going to break in the morning, they take it, or evening they take it, whatever, just remind them of the issues associated with it. There's no general guidance about the use of SGLT2s in Ramadan, but I think you need to be more careful because the fasting periods can again make them prone to developing DKA. So you just need to be wary about that. Advise them. I mean, I'm not sure whether there's a diabetes and Ramadan guidance has put up something about SGLT2s and Ramadan, which will be worthwhile looking at. But generally, there is no reason to stop it as long as you give them good advice about how to fast appropriately.
And again, it's that planning, isn't it? So again, if you know somebody will be fasting for Ramadan, it's important to bring them in beforehand, because it's, you may want to look at people's insulin, sulfonylureas. So it's the whole picture that you want to be looking at. And as Naresh mentions, the DAR guidelines, go on the South Asian Health Federation website, some fantastic resources on there, absolutely brilliant. And somebody's actually just put in the on the chat box about the South Asian Health Federation.
Karen, yeah. Thanks,
Karen.
Brilliant. So if a patient gets DKA whilst on SGLT2, would you consider continuing it once they are well?
No.
No.
So if it is directly related to the DKA, absolutely not. I wouldn't start the SGLT. Is that right, Laura? Would you agree?
Absolutely. If you look at the American Diabetes Association, the traffic light system, that's the main thing in the red column point.
So
Previous DKA.
That was an easy one. So someone's written about who produces the What Next After Metformin leaflet. I believe we put the link for that in.
So that's one of our colleagues on the Primary Care Diabetes Society Committee, Kevin Fernando. He's a GP in Scotland, and he's got some really good shortcuts. There's a very good one on renal prescribing, which he's updating, just as DAPA got its new license last week. And this a really good one on the classification of diabetes as well. So we put the link in there.
So if you can forward it on to them, Hope, the links for both the notebook and the ADA ESD, because Laura put up the ADA ESD guidance, and You know, things are changing so rapidly, they produce another blooming one. So it's not much different, but I think it highlights certain differences. So that's in the chat box as well, if you just pass them on.
Yeah, absolutely. We'll make sure that they get emailed out after the webinar's finished. So would you hold SGLT2 in patients admitted to hospital, even if the reason for admission is not due to infection?
So that would be up to your inpatient teams. So most hospitals, not all yet, but most hospitals would have an inpatient diabetes team, and they would make that decision on whether they would continue them. Like you say, if it was a well person, but one thing that's really important is that SGLT2 inhibitors should be stopped prior to surgery. So that's part of the preoperative planning for somebody. There's just been some really great work done by the Getting It Right First Time. There's some new preoperative guidelines for people with diabetes, and that's really important at the moment because we've got a massive backlog from COVID of surgical procedures, and actually a lot of people with diabetes are getting the surgery cancelled because the HbA1cs have gone too high. So do have a look at that, and some really good resources for people with diabetes from that Getting It Right team.
I think the important thing is the inpatient team will make the decision based on the reason for admission. All right. So if they're dehydrated, gastroenteritis, all these things which can predispose for everything, they'll stop them. And like Nikki says, if they're going for surgery, they'll stop them. All right. But there might be other reasons they're admitted which does not need it. But the main thing again is restarting these therapies post. All right. So make sure that when they come out, as Laura knows, that she's nodding her head, so, about restarting these therapies, which is where we fail a lot.
Okay, thank you. So why is Inovacana the first choice for SGLT2, and what's the rationale behind
So
that?
this is where I think Laura probably said Inovacana's first choice. It's not really the first choice, Laura. I'm sorry. It is actually just put in alphabetical order, that's all. All right. So the first choices are canagliflozin because it starts with a C, DAPA because it starts with D, EMPA because it's an E after that. Does not make them. So any of those are first choices. All right.
Okay, you learned something new on your own webinar.
Exactly.
I mean, but it's easy though,
It's
isn't it, Laura?
misleading because
you can look at it and think, oh, first choices. Oh, it says Cana. I better use the Cana one. But no. So any of those are first choices. All right. But use them appropriately. That's the main thing.
Oh, brilliant.
And your patient that you got on as a case study, fantastic cases. Yeah, give them SGLT2s.
Yeah.
Brilliant. What would you do if a patient wasn't tolerating SGLT2s?
We'll let Laura answer that.
Yeah, I mean, a lot of the time it's a case of, assessing what medications they're on. I would tend to go through and say, okay, I notice you're on, let's say it's canagliflozin. How are you finding that, especially if it's a new medication that's just been prescribed? How are you finding it? Have you noticed you're going to the toilet more often? And it's really important to say, is this more often for you? Is this not normal for you? And even if it is not normal for them, is it okay? Are they tolerating it? Because if they are going to the toilet once in the night, but it's not bothering them, if it's not a problem for them, I would just keep them on it. But a lot of the time, the patient will guide you into how they're tolerating it, and if they're not tolerating it, they will very much tell you in clinic.
It's true. I think that's exactly what you should be doing, because when people say they can't tolerate the drug, it's like statin intolerance, why, what is the problem with it? Have you explained to them the side effects and everything? Are they coping with it? And has it made a difference to their weight, their HbA1c, all these things, and if it is, and is it some of the side effects that they can cope with or not? Obviously, if they're not coping with, you have to consider the long-term adherence and compliance with these therapies, and then you might want to change it to something else if they feel, no, actually, I can't cope with this thing. But then that's an individualized decision, isn't it, Nikki?
Yeah, again.
Okay, so I've got a few questions about whether we should be providing ketone meters and strips.
I think every webinar I've done since the beginning of COVID, I've been asked that one. It's quite a hot topic, and certainly there are groups, well, there's opinion to say actually if there's a potential for DKA, then give everybody a ketone meter. But the education has got to go in there if you were going to do that. It's not as simple as just giving somebody a ketone meter, it's knowing when they need to test. And if people are following correct sick day guidelines, then they should be safe from getting a DKA. Not always, not 100%. What we actually did locally, because it's not in the national guidelines to be giving out ketone meters, and actually where we did an audit in practice with Naresh in GP practice when I was working there, we actually found that not all of our people with type 1 diabetes had a ketone meter, or if they did, their equipment was well out of date, because thankfully it's very rare that somebody needs to use it. But what we did, what we've done locally is we've made sure that every hot hub during COVID times had access to a ketone meter. And certainly on the Easter Sunday, I went round, not quite like the Easter bunny with Easter eggs, but with ketone meters. And I know you got one, didn't you, Laura? So at least at the surgeries. And I think Laura brought up a really interesting point that you know, people with type 2 diabetes will get this euglycemic DKA, so their random glucose might be quite normal, but they're going into DKA. Now, we've all just been on this webinar, so we've heard this information now, but actually our fellow colleagues that aren't here and they're not diabetes specialists, they don't know that. So if they see somebody with a chest infection or somebody that's got a viral infection, running a high temperature, they're becoming dehydrated, they might think, oh, well, it's type 2 diabetes, I don't need to look for DKA. So it's about us all going back into practice and making sure our colleagues are educated to know that if somebody with type 2 diabetes is taking an SGLT2 inhibitor, then we should always check for ketones, even at a normal glucose level.
So the short answer is no.
No ketone meters,
but I think what you could do immensely is make sure your practice has one and it's functioning, all right, and it's working and people know where it is. Patient turns up unwell on SGLT2, do the ketones on them, all right, so that's important.
Okay, brilliant. So we've had a question about whether it's okay to stop SGLT2 when a patient is undergoing chemotherapy and has a low appetite.
Good question again. I mean, it has a low appetite. There's no contraindication of using SGLT2s when somebody's undergoing chemotherapy. Are there other reasons? Because SGLT2s bone by themselves cause a low appetite or promote appetite loss. So I think it's more GLP-1s that promote appetite loss. So I think it's an, again, individual thing which will be difficult to answer or as a blanket answer. I think it's got to be thinking individually what the issues with this person with diabetes are. So chemotherapy and SGLT2s, it's okay as long as the renal function and everything else is fine.
But I would watch the blood glucose levels, make sure that person's got a meter, because quite often with the treatments for chemotherapy, then the blood sugars can go quite high. And as Laura mentioned, you wouldn't be wanting to use an SGLT2 in somebody with high blood glucose levels because of that DKA risk. Certainly, I can't remember the group that have just brought it out, but there are some new diabetes and cancer guidelines which have just been published, but I can find out those guidelines. They're just not at the top of my head, and I'll get those through to you.
Yeah, thank you. So we've got a question from a heart failure nurse, and she's asked, what happens if a patient has type 2 diabetes and is taking insulin? Do the insulin doses need to be adjusted?
Yeah,
Again, go on, sorry, Laura, go on.
All right, yeah, I was just going to say, basically, it's if you just want to be mindful that they don't cause hypoglycemia, but if mixed with things like insulin, they could do. So that's where your dose adjustment, you may need to look at that in clinic. Sometimes, normally in clinic, if we start someone on SGLT2, we will review them, say, about 3 to 6 months afterwards. But you may need to bring that forward a little bit if you're worried about hypoglycemia. And you could potentially also give them a glucose meter, even if it is only for the short term. But they should technically have one if they're on insulin, but not all the time.
And I think another thing that you do very well, you and your team there, Laura at Robert Darbishire, is you will phone these people, won't you? So normally if you've put an SGLT2 or a GLP-1 or any other medication in with insulin, I know that you do phone the patient sort of, within a few days, the next week, just as a short intervention, just to make sure that that insulin, if it needs titrating, then it is done so safely.
So for the heart failure question, so there's absolutely no, yes, you monitor the, like Laura says, glucose meter, monitor the glucose levels or just the insulin. And again, remember about the EGFR levels. I mean, below 45, the fluorescents don't work for glycemic control. So if you're using it for heart failure, that's completely different, all right? So, and it doesn't affect the glycemia, but still, as a caution or a precaution, you would still check use the glucometer and just make sure that they're not having hypos.
And I would just, I'm just sort of skipping on because we're talking about heart failure there, you're sort of touching on additional benefits of the SGLT2 inhibitors, and Laura mentioned the cardio-renal protection. Somebody's put in the Q&A about the KDIGO guidelines, but we got new NICE guidelines for CKD published last week.
Yeah.
So they are suggesting now anybody with a microalbumin over 30 that we look at starting them on an SGLT2 inhibitor. So a lot is changing where we're using them now, not just for diabetes, but we are using them for heart failure and renal protection.
Hope, sorry, there's a question I just need to quickly tackle that. It says, what to do with the EGFR falling and SGLT2 if it's been started for glycemic reasons? Any thoughts on that, Laura? I think.
Sorry, I didn't catch that there. You broke up there. What was that?
What would you do if the EGFR is falling and then SGLT2 has been, what would you do with the SGLT2 if it has been started for glycemic reasons?
Again, you would just be mindful of that. If it is falling, you need to do the dose adjustments based on the BNF guidelines. That's not something that we necessarily do too much because we're not prescribers, but it's something that we would just maybe highlight to a GP that, oh, I've noticed we've seen this patient for their diabetic review, their EGFR has gone from whatever it is to say 30 or whatever it is. Would you want to look at amending the medication, particularly the SGLT2?
So the thing to consider here is, one is, why is the EGFR falling? All right, so that's a big thing. All right, why did it fall? When you start an SGLT2, there's a 4 to 5 mil drop in the EGFR anyway, so don't check the EGFR in the first 4 weeks. Then if it's using it and then the EGFR is falling and it's falling below 45, you have to think about something else for glycemic control, because the SGLT2 will be ineffective for that. So you have to think of alternative medications. That's the important thing to consider there. But always remember, why is the EGFR falling? Why is it dropped? If anything drops below 5 mils per minute over the year, you need to try and look at it and think, well, is there any other reason? Again, are they on simple things like NSAIDs and things like that? Those are simple things to consider.
And again, in the new CKD guidelines, there's a section a little bit around EGFR drop and when you would need to refer to a specialist team. So
there would be local guidelines on that
as well.
Okay, brilliant. Unfortunately, I do think that that's all we've got time for today. Thank you so much, Laura, for a fantastic presentation. And thank you
to Nicola and Naresh for joining us as well.
Yeah.
Oh, you've done a fabulous job, Laura. I think it was really,
absolutely.
And it was really interesting. So there you go. Well done.
Thank you.
Yeah, brilliant. So thank you all. Yes, thank you as well for Nicola and Naresh for joining us for the questions. Hope that you all found it really useful. Thank you, Laura, Nicola and Naresh. Goodbye.
Thanks. Bye.
Bye.